Bismillahirrahmanirrahim. Question number 57. A 64-year-old man present with a 2-month history of cramping pain in the right buttock. This pain only appears when he is walking and comes on after several minutes. The pain radiates from the buttock down the right thigh and goes away when he stops walking to rest. Which one of the following is the most likely explanation for his symptoms? So options are the stenosis of right common iliac artery, spinal canal stenosis, L4-5 disc prolapse, stenosis of his right superficial femoral artery, osteoarthritis of his right hip. So the buttock and thigh muscle ischemic claudication, pain on walking relieved by rest, is due to obstruction of the common or external iliac artery by plaque or thrombus. So correct answer is the common or external iliac artery. The typical symptoms of occlusion of the superficial femoral artery is cough claudication on walking and would not involve the buttock or thigh musculature. Ischemic muscle pain becomes progressively severe with increasing effort, and thus the onset may consistently relate to given a distance walked. Spinal canal stenosis due to disc or facet joint encroachment usually affect the mid or lower lumbar spinal cord and can cause nerve root impingement symptoms, with pain aggravated by walking and requiring a recumbency for relief. Pain distribution is related to lower lumbar dermatome segments rather than to ischemic muscle groups. Focal L4-5 disc prolapse laterally can also cause unilateral nerve root impingement symptoms, which are not specifically related to walking. Prolapse at L4-5 usually compress the nerve root corresponding to the lower vertebra L5 root with shooting pain, then resulting from the low back down the back of the leg and extending to the inner toes. Feelings of numbness or paresthesia is associated and the associated dermatomes are often associated and described as pins and needle, electric shock, or loss of feeling. Associated motor weakness of L5 myotome can affect the extensor of ankle and great toe, causing foot drop. Pain is exacerbated by lifting strain. So the uh, pain is exacerbated by lifting strain, by coughing, sneezing, or by standing at a stool. Osteoarthritis of the hip causes pain localizes diffusely and deeply around the joint, which is worse on prolonged standing or walking or with the effort lifting. So the correct answer is stenosis of his right common iliac artery. A 65-year-old patient present with history of severe abdominal pain, shock, moderate abdominal rigidity, and intensity lower back pain and intense lower back pain. This presentation is most characteristic of which one of the following condition? 65 old with history of severe abdominal pain, shock, moderate abdominal rigidity, and intense lower back pain. The options are acute retrocecal appendicitis, leaking aortic aneurysm, renal colic, acute cholecystitis, collapse of L1 vertebral body. The patient presenting with abdominal pain have an important subgroup acute abdominal surgical emergency in which the severity of the pain and associated features of prostration and peritonitis mandate that consideration of treatment by urgent surgery is required soon after presentation. In these patients, surgery comprises an important differential diagnostic investigation as well as being the best and most urgent form of therapy. The patient falls into that category. The clinical picture is classical leaking and aortic aneurysm and emergency surgery should be followed as soon as possible without procrastinating investigational delay. So this answer is the leaking aortic aneurysm. The other differential diagnoses cover the range of acute intraperitoneal condition, acute cholecystitis, retroperitoneal pathology, renal colic, retrocecal appendicitis, and extra-abdominal causes of acute abdominal pain, vertebral collapse, but none is as likely as leaking aneurysm with this scenario. Acute cholecystitis with perforation may give a generalized peritonitis and shock, but back pain would not be the feature. Acute retrocecal appendicitis may, if perforation ensue, cause generalized peritonitis, but more usually symptoms and signs are localized to the right lower abdomen, often with a phlegmous mass which may be palpable. Renal colic causes acute and intense back and loin pain, but shock and abdominal rigidity are not featured. Collapse of an osteoporotic vertebral body with back pain more often follows as a stain of all shock and abdominal rigidity are absent. Another condition not given as an option, which is more likely to cause a diagnostic difficulty under the above circumstances, is acute hemorrhagic pancreatitis, acute pancreatic necrosis. Such a patients can present with severe epigastric or generalized abdominal pain, radiating to the back with sign in abdominal tenderness and muscle guarding without board-like rigidity, but with marked release tenderness and with severe shock. An associated history of gallstone or high alcohol intake may be helpful, and abdominal imaging by CT scan is usually diagnostic. Shocked patient must be under constant medical supervision and appropriately monitored during imaging. The distinction is important as early surgery is not usually recommended if pancreatitis can be diagnosed with certainty. Others within the group of acute abdominal surgical emergency and which require immediate surgery are perforated peptic ulcer and acute intestinal obstruction with strangulation, perforated diverticulitis, perforated appendicitis, and perforated cholecystitis. So here the correct answer is leaking aortic aneurysm.